Aerobic gram-positive bacilli. So patient, 76-year-old female receiving corticosteroid therapy for a malignant tumor, fever and headache of 7 days duration. Headache became progressively worse and temperature was elevated. CBC is slightly elevated with normal distribution. 250 white blood cells per mil in the cerebrospinal fluid. Glucose is 30 mg per deciliter. Serum glucose was 105 mg per deciliter. Protein 180 mg per deciliter. CSF initial culture results, direct specimen gram smear, no bacteria observed, but beta hemolytic colonies seen on sheep blood agar 2 days later. CSF isolate results, gram stain smear of the isolate, pleomorphic gram-positive non-spore forming bacillus, catalase positive, asculin positive, hippurate positive, mobile at room temperature, but not at 35 degrees Celsius. Camp test, Christie, Atkins, Munch, Peterson, camp test positive, block, but not arrow-shaped. After reading the patient's case history, consider key tests to be performed to differentiate non-spore forming gram-positive bacilli, factors that increase an individual's risk for infection, and the distribution in nature of non-spore forming gram-positive bacilli and species that constitute the normal bacterial biota of humans. Aerobic gram-positive bacilli are a large, diverse group of bacteria. Some are spore-forming, some are non-spore forming. And by spore, we're talking about that endospore. If you remember from previous classes, when you learned about certain types of bacteria, they're able to produce endospores. And what an endospore is a super dormant form of the bacterium. It's almost like a bacterial seed. So a bacterial cell will copy its genetic material and then create this super tough, weather resistant, UV resistant, disinfectant resistant capsule type enclosure for that genetic material. And the whole bacterial cell will die, leaving behind this spore called an endospore. Now that endospore, when placed in the correct conditions, can then hatch open and become a fully functional bacterial cell once it gets into those correct conditions. Endospores are resistant to almost everything out there. So they resist antibiotics, they're resistant to UV, to disinfectants, antiseptics, all sorts of different things. It cannot penetrate into it and deactivate those endospores. Not all bacteria are spore formers. So there's spore forming and non-spore forming. And then there's branching non-spore forming gram-positive bacilli. They're commonly encountered in clinical microbiology laboratory, and most members are not highly pathogenic. So here, if we look at a gram-positive rod, also known as gram-positive bacilli, we have the non-spore former group and the spore former group. Of the spore formers, we have Bacillus, and then we have Bacillus species and Bacillus anthracis. Bacillus anthracis is anthrax, so that's the really bad one, and we'll get to talking about that in this lecture. But then we have our non-spore formers, and there's various types. And then if we break them down into whether or not they're branching, there's some branching ones and non-branching. Branching just means that the cells are elongated and looks like they're forming the branches of a tree. Then we look at catalase. Some are catalase positive, some are catalase negative. For the catalase positive ones, they can be broken down further by their motility and bile-esculin hydrolysis. And then the catalase negative ones can be divided by H2S production. These types of flowcharts are going to help you internalize and remember some of these test results to be able to differentiate them on an exam. So if you get our exam for this course or the qualifying exam in order to become an MLT, ASCP certified laboratory technician, on that exam, it may give you a series of results, and it may say you have a gram-positive bacillus that is catalase positive and motile at 22 degrees Celsius or 25 degrees Celsius and bile-esculin positive. What is the most likely species? So if you have these flowcharts and you've created them and you kind of use these as your basis for studying for that qualifying exam, you'd be able to answer a lot of those types of questions. And that's only a portion of the questions, so keep that in mind. So starting off with the non-spore forming, non-branching, catalase positive bacilli. So they don't spore or form spores and they're not branching. Catalase positive. Corynebacterium species. So general characteristics, these are a diverse group of bacteria. There are animal and human pathogens, saprophytes and plant pathogens. Most members are found in normal biota of humans and animals. They can be found in skin and the mucous membranes. Based on 16S RNA sequencing, these members are closely related to Mycobacteria and Nocardia. There's two categories, non-lipophilic and lipophilic. Lipophilic are fastidious, slow growers. They require at least 48 hours of incubation to grow, but if lipids are in the culture medium, they grow a lot faster and their growth is enhanced. Gram-stain characteristics of Corynebacterium species, they're slightly curved gram-positive rods, unparalleled sides, and slightly wider ends. They're often described as club-shaped or coroniform. Gram-stain appearance often described as diphtheroid or diphtheroid-like for non-pathogenic species. Corynebacterium diphtheriae is the most significant pathogen. It causes diphtheria. So if you've heard of the DTaP or Tdap vaccines, the D in both of those is referring to diphtheria. Other species may cause infections in immunocompromised hosts. The diphtheria toxin is the major virulence factor. It's produced by strains of C. diphtheriae with a lysogenic corynephage that carries the tox gene for the toxin. Toxin-producing C. diphtheriae causes diphtheria. Other Corynebacterium species can also carry the gene and produce the toxin. So this toxin is a protein that's composed of two fragments. Fragment A is responsible for the cytotoxicity. It disrupts protein synthesis. And the B portion binds to specific cell membrane receptors. It mediates entry of fragment A into the cytoplasm. Diphtheria is acquired by droplet spray or hand-to-mouth contact. In unimmunized individuals are susceptible. Symptoms, incubation period, so before you start to show symptoms after you've been exposed, it takes about 2 to 5 days. Starts with a low-grade fever, malaise, mild sore throat. Local toxin production causes tissue necrosis, and that forms a tough white to gray pseudomembrane. And I've highlighted this because this is the main symptom that differentiates diphtheria from most other respiratory infections or throat infections. It starts at the tonsils and spreads downward into the larynx and trachea. This membrane is so tough and so thick that it may obstruct breathing. So sometimes it forms such a film layer of tissue in the back of the throat that you can't get anything past it. Like you can't swallow food and it interrupts breathing. Systemic effects. The toxin is absorbed in the bloodstream and carried systematically. It affects the kidneys, heart, and nervous system, sometimes cause demyelinating peripheral neuritis, resulting in paralysis. Death often results due to cardiac failure. The cutaneous infections occur much less often than the respiratory infection. The toxin is absorbed systematically, causes non-healing ulcers with a dirty gray membrane. Outbreaks may occur by close person-to-person contact, often recovered along with S. pyogenes and S. aureus, but it's unusual in the United States. Prevention, there is the vaccine, so it's part of trivalent diphtheria, tetanus, and pertussis, acellular pertussis for pediatric formulations. Children receive a series of 5 injections beginning at 2 months of age, with the 5th administered between 4 and 6 years of age. A combination diphtheria tetanus vaccine is recommended every 10 years thereafter. The vaccine induces antibody to diphtheria toxin, preventing the disease, but not infection by C. diphtheriae. Microscopy, gram-positive, pleomorphic, and non-spore-forming bacilli that appear as palisades or parallel rows, sometimes referred to as Chinese letters. So looking at this picture here, you can see it looks like a bunch of parallel rows, and sometimes they are at an angle from one another. Club-shaped, sharp angles that resemble the letters V and L. Methylene blue stain, beaded appearance, possesses metachromatic areas that stain notably more intensely, called Babe's earnest granules. Culture characteristics. Facultative anaerobe grows best under aerobic conditions. Optimal growth temperature is 37 C. Multiplication occurs within a range of 15 C to 40 C. Grows on nutrient agar but does better on specialty media. Loeffler's serum agar or cysteine tellurite agar, CTBA, black or brownish colonies due to the reduction of tellurite. Not unique, other organisms may produce these colonies as well. So this is a picture of it growing on a plate. Identification methods. Medically important species are catalase positive and non-motile. MALDI-TOF, mass spectrometry, and toxigenicity testing is available. And here is a breakdown of different types of Corynebacteria species. And another flowchart for the identification of Corynebacterium diphtheriae. The ELECT test is an immunodiffusion test. Organisms consisting of controls and unknowns are streaked onto medium of low iron count. Each organism is streaked in a single straight line parallel to each other, 10 millimeters apart. A paper strip that's impregnated with diphtheria antitoxin is laid in the center of the plate, on a line at right angles to the inoculum lines of the control and unknown organisms. So just showing you the picture of this, here's the plate. Here is the antitoxin impregnated filter paper strip. So it's antibodies against the toxin. The plate is incubated at 35 C and examined after 18, 24, and 48 hours. Lines of precipitation are best seen against a dark background. White precipitin lines start about 4 to 5 millimeters from the filter paper strip and are at an angle of about 45 degrees to the line of growth. This is known as the zone of equivalence. So here you can see this is a positive test, and you have this precipitin line that's coming out. So how this forms. Positive for toxin production is indicated by an arch of identity. The ELECT test requires that reagents and antisera be carefully controlled and titrated. So here you have the bacterial growth. So here's your antibodies against that toxin. And here's sample 1, sample 2, sample 3, sample 4. Now sample 4 is negative for the toxin. So as this antitoxin seeps out into the medium and it goes around the growth, it's not going to come in contact with any toxins, so you don't see any precipitation line form. Up here though, you see that if this one is producing toxin, the toxin is going to come out in different directions here. So the toxin is going to be diffused out into the agar from that organism. Now, as the antitoxin or those antibodies diffuse out into the agar, they're going to reach a point where they're in perfect combination with the toxin that was produced, and it forms this line of precipitation. So you can actually see this precipitation line in the agar, and that is a positive result. And that's saying that this organism, number 1, is a toxigenic strain. It produces the toxin, and that toxin is being picked up and detected by the antitoxin that was in this membrane. So 1 is a positive control. 2, we don't know what it is, but now we know it's toxigenic. It produces toxins. 3 is a negative control, and 4 is unknown. But it's non-toxigenic. So you can see these different species and the bands that will or will not be produced based on whether or not it has that toxin. Treatment, administer antitoxin. The focus is getting rid of the toxin. Now, we do treat and kill the bacteria very easily with penicillin, but we want to make sure that that toxin is taken care of because it's the toxin that causes most of the severe symptoms that lead to death. There's other Corynebacterium, like Amiculatum. It's common in skin and most frequently recovered species. Opportunistic infections can occur. Jachium, infections are limited to immunocompromised patients. Pseudodiphtheriicium is part of the normal biota of the human nasopharynx. Opportunistic infections are rare. Has been identified and associated with ventilator-associated pneumonia in cases of COVID-19. And then there's various other species that exist. Again, for this qualifying exam, you don't have to know every species on Earth. It's just good to be familiar with them or have seen them at least once in your life prior to taking that qualifying exam. Corynebacterium should be identified to the species level, especially if it's isolated from a normally sterile site, predominant organism from a properly collected specimen, or if it's in urine samples and it's the predominant organism, the total colony count is greater than 10 to the 5 mils, CFUs per mil, or they are the sole isolate within a colony greater than 10 to the 4th CFUs per mil. Methods for identification. Primarily, we just use the MALDI. There are some rapid tests. You can use a microscan ID panel, the Vitek 2 card, and conventional biochemical testing is also available. Listeria monocytogenes. It's an important human pathogen that's widespread in the environment, soil, water, vegetation, animal products. It's known to cause illness in numerous wild and domestic animals. Humans and animals can serve as asymptomatic carriers. Known virulence factors are listed, and it survives initial host defenses. Each of the virulence factors plays a role in the invasion process. The infectious dose of listeriosis is not well understood. Majority of the infections are caused by ingestion of contaminated food products with subsequent spread through the intestine. The clinical manifestations of listeriosis differ among patient groups. In pregnant women, it's most common in the 3rd trimester. L. monocytogenes is responsible for spontaneous abortion and stillborn neonates. Progression is flu-like illness with fever, headache, and myalgia. It may result in premature labor or septic abortion within 3 to 7 days. Infection is often self-limiting. In the newborn, it's extremely serious, with fatality rates approaching 50% if the fetus is born alive. There are 2 forms: early onset that results from intrauterine infection, and late onset occurs several days to weeks after birth. It most likely manifests as meningitis, potentially fatal. Diseases in the immunosuppressed host, older adults, patients receiving chemotherapy, young children. The fatality rate is high in older adults and chemotherapy patients. Manifestations are typically CNS, infection, and endocarditis, so meningitis and heart infections. Diagnosis is made by culturing it from the blood or CSF. Listeriosis infections in apparently healthy people and their treatment options. So disease in the apparently healthy individuals are commonly in the intestinal tract involvement from eating contaminated food. Examples include cheese, ice cream, hot dogs, lunch meats, coleslaw, chicken. There's a huge listeria outbreak recently in the United States over cantaloupe. The problem with listeria is most of the time we use a refrigerator because cold temperatures will slow down the growth of many microorganisms. Listeria thrives in colder temperatures. So if you put contaminated food items in your fridge, listeria will grow unchecked and grow better than it would at our incubation temperatures of 37 degrees Celsius, or at least as equal as it would in the fridge as it would in the body or in the incubator. Possible effective treatments include penicillins, aminoglycosides, macrolides. For Invasive diseases, ampicillin or penicillin in combination with gentamicin. Identification, gram-positive non-spore-forming coccobacilli. Coccobacilli are just really short rods. Microscopy and culture, coccoidal. With age, it may be gram variable, so older colonies may be gram variable. Can resemble streptococci. Here's a direct smear and a smear from culture. Grows well on SBA and chocolate agar and prefers slightly increased carbon dioxide. Colony is small, round, smooth, translucent, and produce a narrow zone of beta hemolysis, similar to group B strep. Cold enrichment. It grows well at 4 degrees Celsius. Here's beta hemolytic growth resembling S. algalactiae, and then the CAMP test showing block hemolysis. It's catalase positive, so it rules out the streptococcus. Positive for hippurate hydrolysis. It's motile at 25 degrees Celsius, and it has an umbrella-type motility, tumbling motility, and hanging drop preparations. So here is a flowchart of positive and negative results to help you distinguish Listeria from Corynebacterium species Streptococcus algalactiae and Pterococcus. Here's a picture of the umbrella motility at 25C. So it looks like it takes on the shape of an umbrella, and here it's negative. CAMP test produces a block type of hemolysis in contrast to the arrow shape produced by group B strep. Can use hippurate hydrolysis test as well. Presumptive identification, microscopic morphology on gram stain, tumbling motility, positive catalase, and esculin hydrolysis. Confirmatory tests would be acid production from glucose, positive VP and MR, and of course you can always use the MALDI. Non-spore forming, non-branching catalase negative bacilli. So Erysipelathrix is found worldwide, can be commensal or a pathogen in a wide variety of vertebrates and invertebrates. A commensal is an organism that does not provide any benefit or harm. So it basically coexists with a host, but there's no benefit of having it there and there's no harm of having it there. Human cases typically arise from occupational exposure. People who handle fish and animal products are most at risk. Usual route of infection is through cuts or scratches on the skin. Organism is resistant to salting, pickling, and smoking. Organism survives well in environmental sources, so soil, water, plant material. Erysipeloid is most common local skin infection that resembles streptococcal erysipelas. Lesions are usually seen on the hands or fingers. Organisms are inoculated through work activities. The infected area is painful and swollen and gives rise to sharply defined, slightly elevated purplish red zone that spreads peripherally as discoloration of the central area fades. Erysipeloid can cause low-grade fever, arthalgia, lymphangitis, lymphadenopathy may occur. Self-limiting infection that normally heals within 3 to 4 weeks but may continue for months. Relapses are known to occur. Septicemia is often associated with endocarditis. It may occur in those who have had valve replacements. Diffuse cutaneous infection manifests as an exacerbation of erysipeloid lesion. Systematic infections are uncommon. The drug of choice for cutaneous and systematic infections is penicillin or ampicillin, and it's routinely resistant to vancomycin. Gram-positive, thin, rod-shaped, pleomorphic. Arrangement on gram smears would be singly, short chains, or V-shaped. And this is what it looks like under the microscope. Carbon dioxide is required. It grows on blood, SBA, or chocolate agar. On SBA, the colonies are usually non-hemolytic and pinpoint after 24 hours. On SBA, after 48 hours, colonies may appear large, rough, flat, with matte surface, curled structure, irregular edges. Colonies often appear as alpha hemolytic after a few days of growth. The broth should be inoculated daily to SBA. So here's the picture of Listeria and erysipelathrix. Aerobic or facultative anaerobe, catalase negative, non-motile, production of hydrogen sulfide on triple sugar iron, Voges-Proskauer negative, and test tube brush-like pattern on gelatin stab culture. MALDI is used for identification. And here's a chart differentiating several gram-positive bacilli species. Gardnerella vaginalis. Gardnerella vaginalis, abbreviated GVAG, or just Gardnerella, is or causes bacterial vaginosis. So it's short pleomorphic gram-positive rod or coccobacillus, often stains gram-variable or gram-negative. In clinical infections, bacterial vaginosis. It's a malodorous discharge. It often is referred to as like fish-like odor, and it is a very strong, pungent fish-like odor. It occurs when the vaginal pH is greater than 4.5. One of the main things to keep the bacterial vaginosis away is to reduce the pH of the vagina. This can be accomplished using various types of vaginal suppositories that are available, but the most common way is to take a lot of vitamin C. Vitamin C is ascorbic acid, and that will reduce the pH of the vagina as it's absorbed through the bloodstream and then passed through the urine. So as the urine goes past the vagina, it will cause those secretions there to become slightly more acidic. Another way that it can be modified is just by having a good set of probiotics in the vagina. So being colonized with good probiotics, lactobacillus produces a lot of acid, and that can decrease the pH of the vagina. Microscopy, wet mounts of vaginal fluids. You observe for clue cells, which are large squamous epithelial cells with gram-variable coccobacilli clustered on the edges. Oftentimes when you look for clue cells, so you'll take a swab from the vagina, you will smear it on a microscope slide, you prepare a wet mount of it, so you can put it in some saline solution and put a drop on the microscope slide. And when you're looking at it under the microscope slide, you will look for the clue cells, and the clue cells are very large cells, and they have almost uneven or undistinguishable borders because of how many bacterial cells are overtaking the surface of them. So that typically indicates that it is some type of bacterial vaginosis. Other very common types of vaginal infections include trichomoniasis, where you have a parasite that's flagellated and you will see it swimming around in the wet mount. And we will talk about that type of parasite when we get to talking about parasitology in advanced microbiology. But when we have those swimming around, those are pretty obvious and they have a very distinctive shape. The other one that's very common would be yeast infections in the vagina. And with yeast, you're going to see very long or very large, elongated kind of yeast-like cells, and you are going to see some budding, and that's kind of a obvious shape. When you see those little buds coming off of the main cells, you can determine that that is more of a yeast infection. But if you see those clue cells, that's something to note. Bacterial vaginosis can also be detected for using molecular tests. So there are vaginal associated molecular tests that test for the genetic material of the yeast. Candida albicans is the most common. Gardnerella vaginalis, which is the bacterial vaginosis, the one that causes bacterial vaginosis, and also that trichomonas. So there's clinical criteria for diagnosis, and it can be used if 3 of the 4 criteria are found. Homogeneous thin white discharge that smoothly coats the vaginal walls, presence of clue cells, pH of the vagina is greater than 4.5, fishy odor of the vaginal discharge before or after the addition of 10% KOH whiff test. DNA hybridization probe test is available. Culture characteristics, SBA or chocolate agar, 5 to 7% CO2 at 35C to 37C. Human blood bilayer tween HBT agar is the medium of choice. Appearance on human blood culture, beta hemolytic small gray opaque, and treatment is metronidazole or clindamycin. And this just shows the Nugent scoring system for gram stain vaginal smears. Non-spore forming branching aerobic actinomycetes. So nocardia are aerobic gram-positive beaded gram-positive bacilli. Beads are not spaced in consistent intervals. Partially acid-fast, also called modified acid-fast positive. Colony and microscopic morphology and types of infections caused resemble that of fungi. So this is what it looks like. And if you've ever seen fungi under a microscope, this is what fungi looks like. So oftentimes if we see this, we kind of think that it's a fungal infection. May be recovered on a standard non-selective media. Growth may take a week or longer. Generally found worldwide and in the environment and mostly affects immunocompromised individuals. Virulence factors. So there's the role of factors such as toxins and extracellular proteins is unclear. Clinical infections, it can cause pulmonary infections or lung infections, occur from inhalation of the organism in soil or dust, associated with impaired host defenses due to underlying disease or compromised immune system. High mortality rate, significant tissue damage among survivors, and disseminated infections involve brain abscesses. Chronic pulmonary infections, most common is confluent bronchopneumonia. The disease progresses more rapidly than tuberculosis, measured in months rather than years. Dissemination to other organs may occur. Acute pulmonary infections are seen in patients with underlying immune defects. It's measured in weeks. Nocardiosis, pulmonary infections. Initial lesion in the lung, often focus of pneumonitis that advances to necrosis. Tissue involvement may occur, resulting in damage. Little inflammatory response or scarring. Sputum thick and purulent, and there are no sulfur granules upon staining. Cutaneous infections occur after inoculation of the organism into the skin or cutaneous tissues. Infection begins as a localized subcutaneous abscess. Refers to as actinomycotic mycetomas. Note, mycetomas caused by fungi are called eumycotic mycetomas. So this is something to make a note of, actinomycotic versus eumycotic. Eumycotic is referring to fungi because it's a eukaryotic organism. Actinomycotic is referring to an actinomycetes-related species of bacteria. As the infection progresses, burrowing sinuses open to the skin surface and drain pus. Pus may be pigmented and contain sulfur granules. So this is collected from draining sinus tracts. Wet mounts crush granules to see cellular morphology. Microscopy, you see gram-positive branching filaments, indirect smears from sputum or aspirated material. May show beading appearance. Beads do not touch each other. Nocardia can be presumptively identified based on observation of filamentous branching isolate that is partially acid-fast on staining. Growth requirements are not well defined. It grows well on most common non-selective media incubated between 22 and 37 C. It may take 3 to 6 days or more before the growth is seen. Thayer-Martin agar may enhance recovery of Nocardia species by inhibiting the growth of contaminating organisms. Chalky, matte, velvety, powdery, white, yellow, pink, or orange, peach, tan, gray, may have dry, crumbled appearance like breadcrumbs. Under a dissecting microscope, colonies may reveal the presence of aerial hyphae. So this is what it looks like on chocolate agar. Identification methods would be the typical biochemicals and MALDI-TOF identification. There's also 16S rRNA sequencing, which is the method of choice currently. Treatment involves the drainage and surgery along with antimicrobials. Antimicrobial profiles vary. It's resistant to penicillin but susceptible to sulfonamides. Antifungal agents have no effect. Nocardia is often present along with other organisms, including fungi. Proper testing and antimicrobial treatment is essential. Other actinomycetes are listed here, so just be familiar with their names. Spore-forming non-branching catalase-positive bacilli. So Bacillus species, stain gram-positive or gram-variable, aerobic or facultatively anaerobic bacteria that form endospores. There's more than 90 species and all are widely distributed in the soil and the environment. Metabolically diverse, and some species are thermophiles that grow best at 55 degrees Celsius or higher. The survival of Bacillus species in nature is aided by the formation of spores that are resistant to conditions to which vegetative cells are intolerant. They grow well on SBA but not Columbia colistin nalidic acid agar, CNA agar. Most species form non-hemolytic colonies and they're catalase positive. Many members of the species are regarded as laboratory contaminants. Many laboratories do not identify Bacillus isolates to the species level, except for Bacillus anthracis. This is the most important member of the genus and considered to be a potential bioterrorism agent. Anthrax was actually used as a bioterrorist attack when the anthrax attacks of 2001 occurred. B. cereus, Biovar anthracis, is added to the list of potential bioterrorism agents in 2016. To date, it's only found in African countries, and it's known to cause anthrax-like disease in several animals, but it's not known, no known human infections of this biovar. Bacillus anthracis causes common diseases in livestock worldwide when vaccine is not used. Human infection is a result of accidental or occupational exposure to animals in animal products. There's 3 forms of anthrax that's recognized in humans: cutaneous, inhalation, or pulmonary and gastrointestinal. Human infection known as anthrax results from wound contamination, inhalation, or ingestion of spores. So wound contamination, this Bacillus anthracis is known to be on the surface of animals. So when a person works in a slaughterhouse and is responsible for like tanning the hide of the animal, so stripping the skin off the animal and tanning that hide, maybe to make leather out of the hide, and they happen to cut themselves or get a puncture wound in their hand, the endospores from Bacillus anthracis can get into there and cause a cutaneous type infection. The cutaneous or skin infection causes a painless black eschar. In other words, a wound that turns black and it severs the nerve endings so you don't feel any pain, and it interrupts the ability to feel pain in that area. And then that eventually needs to be treated with antibiotics. If it is left untreated, sometimes that infection can disseminate deeper into the body and become more of a systemic or body-wide infection, and that is when this can become fatal. Inhalation anthrax is fatal. So that's when you inhale it into the respiratory tract, and it can replicate immediately and disseminate deeper into the body, causing a systemic infection. There's also the ingestion of spores, which can cause violent intestinal disruption. Injectional anthrax is when anthrax gets injected. It's a 4th form that's now recognized. It results from the injection of spores into tissue, generally during the administration of drugs of abuse. So sometimes when people are injecting drugs like heroin, they happen to get the needle contaminated with some of this Bacillus anthracis. They inject it into their skin, and now they've got that anthrax that's spreading in their skin. So the cutaneous form, as I mentioned, this constitutes about 99% of anthrax cases. A small pimple or papule appears at the same site of inoculation 2 to 3 days after exposure. And then it turns into this dark black necrotic center or eschar. It begins to heal after 1 to 2 weeks. The lesion dries and eventually falls off, leaving a scar. It's usually a localized infection but can spread. No systematic symptoms are present. Those treated usually survive. Also, the inhalation form, also known as pulmonary anthrax, acquired through the inhalation of spores, mild fever, fatigue, and malaise 2 to 5 days after exposure to the spores. It's similar to the flu or common cold, lasting 2 to 3 days, and then there's sudden respiratory distress, disorientation, coma, and death. Death may occur in less than 24 hours from onset. Acquired by ingestion of spores, the GI form, via contaminated raw or undercooked meat, inoculates into a lesion in the intestinal mucosa, abdominal pain, nausea, anorexia, vomiting, and sometimes bloody diarrhea. More likely to be fatal but less likely to occur than the cutaneous form. Difficult to diagnose, and it accounts for less than 1% of infections. The injectional form, soft tissue infection associated with skin popping or other forms of injection drug use. Direct injection of spores does not form the black eschar, can cause necrotizing fasciitis, organ failure, shock, coma, and meningitis. Very high rate of mortality. Complications: about 5% of people with anthrax develop meningitis, more commonly seen in the inhalation and injection forms. It rapidly develops unconsciousness and death if they occur. Follow 1 to 6 days after initial exposure. There is an effective vaccine available. Cell-free cultured filtrated bacterial proteins absorbed in an albumin salt. Microscopically, large square-ended gram-positive or gram-variable rods, singly or in chains, bamboo appearance, spore-stained on direct samples, positive. Colony morphology, non-hemolytic on 5% blood agar, gray, flat, irregular margin, medusa head or beaten egg whites. This medusa head or beaten egg whites always comes on back on tests. So I've seen this so many times in a lot of different practice questions and on the actual qualifying exam list of potential questions. This is how they really identify or start to describe that Bacillus anthracis. So medusa head or beaten egg whites. When you look at the colony, oh, and I don't have a picture of the colony, but when you look at the colony itself, it looks kind of like wavy, and it looks almost like there's little snakes coming out of the end of the colony. And then when you touch it and you pull it up, sometimes they refer to this as the string test. When you touch it with a loop, it'll like stick to the end of the loop and it'll form a string when you pull it up. It also looks like beaten egg whites to some people. It may show weak beta hemolysis. So this is what it looks like under the microscope. Identification: if any anthrax is suspected, you work under a biosafety hood. You want to see that it's catalase positive, it grows aerobically or anaerobically, ferments glucose, does not ferment other sugars. It's non-motile at those higher temperatures, and so you see this umbrella motility at lower temperatures at 25 degrees Celsius. Direct fluorescent antibody assays are available, and antimicrobial susceptibility testing is performed by reference or national laboratories. We typically wouldn't perform those additional tests in a typical hospital laboratory. So then moving on to Bacillus cereus, B. cereus. Usually non-motile hemolytic on SBA, but there are usually non-hemolytic on SBA and motile. The exception would be goat strains from the Democratic Republic of the Congo. They are non-motile. To differentiate the two, here's a chart that kind of shows you some of the different characteristics. Treatment: most isolates are susceptible to penicillin. Resistance can occur. Ciprofloxacin is the primary recommended antibiotic in most cases, either alone or combination with other antibiotics. Bacillus cereus food poisoning. It's caused by distinct enterotoxins. Manifests in two different forms, the diarrhea and emetic form. Diarrheal syndrome is associated with meat, poultry, vegetables, and pastas. Incubation period of 8 to 16 hours. Abdominal pain and diarrhea. Fever is uncommon and it resolves within 24 hours. It's indistinguishable from that caused by anaerobic bacterium Clostridium perfringens. The emetic form is caused by distinct enterotoxins, nausea and vomiting 1 to 5 hours after ingestion of contaminated food. Diarrhea is present in about 1/3 of those infected, and this is associated with fried rice. It's said that the Bacillus cereus, which is widely dispersed in the environment, happens to go on rice, and then the rice sits there for a period of time, and rice doesn't hold its temperature for very long, so sometimes it's hard to keep rice warm. So as it starts to cool, this starts to overgrow, and it deposits that toxin on the surface of the rice. Then you go to eat it, and you end up getting pretty sick from it. And here's the type of enterotoxin, diarrheal versus emetic symptoms caused by B. cereus. It can cause eye infections, and then there's rare infections in immunocompromised or immunosuppressed and post-surgical hosts. It grows on SBA, incubated at 37C, beta hemolytic frosted glass appearing colony. This one, Bacillus cereus, I've heard it referred to as frosted glass colony. On gram-stained, spore-forming, gram-positive bacilli, it's motile, able to ferment salicin and lecithinase positive. So this is what it looks like on a plate. Treatment, it's resistant to penicillin and resistant to all other beta-lactam antibiotics except for carbapenems. Treatment with vancomycin or clindamycin with or without an aminoglycoside has been successful. The thing about the Bacillus cereus is typically the bacteria doesn't need to be treated. The bacteria dies relatively quickly once it's in the body. It's the toxin that's the issue. And most of these infections are self-limited, where symptoms disappear within 8 hours of you consuming the infected food material. If symptoms persist, and if this organism starts to replicate inside of the body, then that's when you would pursue antibiotic treatment. Other Bacillus species are listed here, usually contaminants. They can cause food poisoning, bacteremia, meningitis, pneumonia, and other types of infections, but here is a list of some of the different species. You can go ahead and review the points to remember, and that is it for today's lecture.